Hello, and thank you for joining us during Heart Failure Awareness Week. We welcome you to today's webinar, The New Heart Failure Guidelines, Impact on the Patient Journey, a Healthcare Professional Perspective. My name is Melissa Clark. I'm the Program Manager for Quality Health here at the AHA. Before we get started, I'd like to go over a few items so you know how to participate in today's event. This webinar is being recorded, and an email will be sent to you about 2 hours after the event, which will include a link to the recording. It will also include a certificate of completion, as we are not offering CEs for this webinar. You will have the opportunity to submit questions by typing them into the questions pane of the control panel. You may send in your questions at any time during the presentation, and we'll collect them and address them during the question and answer session at the end of today's presentation. If you experience any technical issues during the presentation, most can be resolved by refreshing your browser. If that doesn't work, try logging out and logging back in. And if you're still encountering issues, please go to the GoToWebinar customer service team. Their contact information can be found in your webinar confirmation email. And we're very pleased to have 3 presenters today to share with you the challenges patients and healthcare professionals face in delivering recommended guideline-directed care and offer some solutions to overcoming these barriers. Our first speaker is Dr. Sabra Lucy. She is the Assistant Professor of Medicine, Division of Cardiology, Advanced Heart Failure and Transplant at Johns Hopkins University School of Medicine. Dr. Lucy will be sharing the guidelines and their unique features, and she'll begin the discussion around the prevention strategies for heart failure stages A and B. Dr. Leanne Leffler, Professor at Lowenberg College of Nursing, the University of Memphis, will then cover the inpatient guidelines for heart failure stages C and D. And Dr. Kyle Laverne, he's the Vice President of Clinical Programs at CenterWell Home Health, and he's going to focus on the transitions of care. Without further ado, Dr. Lucy, please take it away.
Good afternoon. Thank you for joining us during Heart Failure Awareness Week. Over the next hour, Drs. Leffler, Laverne, and I will be discussing the new heart failure guidelines and the impact on the patient journey from our perspective as providers. I have no relevant financial disclosures. As you all know, heart failure will impact an estimated 8 million Americans by the end of this decade. And within the last decade, we have seen a rise in heart failure-related deaths and hospitalizations. Though there has been a decline in heart failure with reduced ejection fraction incidence, we have concomitantly seen an increase in the heart failure with preserved ejection fraction population, really with a paucity of therapeutic options until now. We also recognize a disproportionate burden of heart failure morbidity and mortality on Black and Indigenous people of color. New heart failure guidelines recognizes this disparity and the need for investigation and policy to address disparate outcomes. To address this significant challenge, the guidelines provides us with a patient-centered roadmap. Really, it provides a common framework in the staging and classification of heart failure to improve patient care. It brings the evidence to bear for the armamentarium of heart failure therapies across the spectrum of ejection fractions. It speaks to the utility of duration of guideline therapies, addresses social determinants of health and disparities, provides value-based assertions regarding heart failure therapeutics, addresses goals of care, timely consideration of advanced therapy referral and comorbidity management, and even addresses special populations, including pregnant women, individuals exposed to chemotherapeutic toxic agents, and those with suspected and confirmed cardiac amyloidosis. So in the next 10 to 15 minutes, I hope to highlight some of the unique aspects of the guidelines and how they may change practice. So we have all become familiar with this across the guidelines history. The guideline solidifies the staging of heart failure severity and reminds us of the unilateral progression from at-risk to symptomatic heart failure and advanced heart failure, highlighting the opportunities for intervention at each stage. Thus, as heart failure providers, our work does not begin at stage C, it definitively begins at stage A in those who are at risk for heart failure, albeit from risk factors that include hypertension, cardiovascular disease, diabetes, obesity, familial risk, or cardiotoxic exposure. Stage B heart failure includes patients without heart failure symptoms but evidence of structural heart disease. They could have elevated intracardiac filling pressures or even risk factors in conjunction with cardiac biomarker or natriuretic peptide elevation. Stage C are those individuals with symptomatic heart failure that's confirmed by signs and symptoms on exam, and stage D are those with refractory or life-altering symptoms in spite of maximally tolerated medical therapy. The systematic assessment of heart failure patients does require stratification by ejection fraction to determine the myopathic process as a reduced ejection fraction, mildly reduced ejection fraction, or preserved ejection fraction with supporting evidence of increased intracardiac filling pressures or natriuretic peptides. And it distinguishes these subclassifications of patients from those who've had a previously reduced ejection fraction that is now improved. So we'll start with stage C. So with an established diagnosis of symptomatic heart failure with reduced ejection fraction and an ejection fraction of 40% and below, the guidelines calls for the prompt initiation of quad-based therapy with RAS antagonists to include the ARNI complex as a de novo therapy. ACE inhibitors or angiotensin receptor blockers can be used in its absence. Evidence-based beta blockers, mineralocorticoid receptor antagonists, and sodium glucose 2 transporter 2 inhibitors with the use of diuretics and decongestants should be utilized as class 1 recommendations of therapy. There should be serial reassessment with labs and health status. In African American patients on these therapies who are already at maximally tolerated doses and remain symptomatic, there's a class 1 recommendation to add the combination of hydralazine and nitrates. In specifically selected patients with their ejection fractions below 35%, they should be considered for ICD therapy. And in those who have evidence of LV dysynchrony, as evidenced by a wide left bundle branch block, who are in sinus rhythm and remain symptomatic, they should be considered for cardiac resynchronization. At any point in time, if these symptoms progress with these guideline therapies, patients should have class 1 recommendations to be considered for a cardiac transplantation or implantation of a durable mechanical assist device. And certainly throughout the spectrum, there should be points of time in which goals of care and specifically palliative care are addressed and explored to ensure patients are informed and empowered. We can advance. There we go. So unique to these guidelines are considerations for those with symptomatic heart failure with mildly reduced ejection fraction. Certainly with new onset or de novo symptoms, these patients should be decongested with diuretics as needed and should be considered for an SGLT2 inhibitor to decrease heart failure hospitalizations and cardiovascular mortality. Use of evidence-based beta blockers has been extrapolated from the HFrEF literature. The ARNI complex, ACE inhibitors, ARBs, and MRAs may also be considered to reduce the risk of heart failure hospitalizations and cardiovascular mortality, particularly in those who have an ejection fraction that falls to the lower end of the heart failure spectrum. With evidence from the TREAD-HF trial, we now have class 1 recommendations that in those with improved ejection fraction on treatment with guideline therapy, they should be continued on these therapies to prevent relapse of LV dysfunction and heart failure symptoms. So even if deemed asymptomatic, these are now long-term therapies to improve long-term outcomes. In the population of patients with heart failure with preserved ejection fraction. So this is certainly a long-awaited broadening of the recommendations to the guidelines in this growing population. We have class 1 recommendations to decongest and attain blood pressure control in these patients, and now class 2A recommendations to initiate SGLT2 inhibitors to decrease heart failure hospitalizations and cardiovascular mortality. Providers can also consider MRAs, ARBs, and the ARNI complex to decrease heart failure hospitalizations, similarly in those who fall to the lower end of the ejection fraction spectrum. Notably, beta blockers are not included in this recommendation. Comorbidity management of atrial fibrillation is also important to improve symptoms, and we are again reminded by the guidelines to avoid nitrates and PDE5 inhibitors due to lack of efficacy in the HFpEF population. So unique to the guidelines is the recognition of social determinants of health and disparate heart failure outcomes and the impact on vulnerable populations with heart failure. The guidelines provides us with a class 1 recommendation in patients presenting with heart failure to thoroughly assess social determinants of health that might cause or accelerate the development or progression of their heart failure. And if disparities or social barriers are observed, there is a class 1 recommendation that these disparities should be monitored and addressed in every setting in which we practice, outpatient or inpatient. In vulnerable populations, we have a class 1 directive to target known cardiovascular disease risk and social determinants, really with the express goal of eliminating disparities in heart failure outcomes. The guidelines writers, they emphasize social barriers we should readily assess in our clinical encounters and offer us with possible solutions that we can leverage in our multidisciplinary care teams for these commonly encountered scenarios. These social barriers are outlined on this slide and include financial burdens, food and housing insecurity, unsafe home environments, language barriers, transportation issues, low health literacy, and inadequate social support. The take-home point here is that there is a class 1 recommendation, and I would say even a directive, to assess, monitor, and address social determinants of health and disparities impacting heart failure patients within multidisciplinary care teams and management across the phases of care. Unique and very important to the new heart failure guidelines are value-based assertions regarding class 1 recommended medical therapies for heart failure with reduced ejection fraction. In particular, the RAS antagonists, including the ARNI complex, MRAs, evidence-based beta blockers, and combination hydralazine and nitrates in appropriately selected patients have high economic value. Furthermore, we know that class 1 therapies such as ICDs and cardiac resynchronization therapy in appropriately selected patients have high economic value. So the guidelines really prepares us as providers and as health systems and leaders of health systems with interventions that not only save lives, but provide economic value in the face of high heart failure healthcare expenditures. Moving on to guidance and the evaluation of patients, the guidelines recognizes that there is some uncertainty in the value of wireless PA pressure monitoring in recently hospitalized symptomatic heart failure patients who are already on optimal therapy. And it also provides us with recommendations for patients who are diagnostically challenging. Particularly, there's class 1 recommendations for the use of exercise and functional capacity testing to risk stratify patients as we consider advanced therapies for them, and a class 2A recommendation for the testing of to assess functional capacity and to better understand unexplained dyspnea. Very importantly, the guidelines emphasizes care and how we define goals of care in our heart failure population, with particular implications for our stage D and pre-stage D heart failure patients. So we have class 1 recommendations to provide palliative and supportive care in the way that we provide care and communicate with our patients. There's class 1 recommendations, especially in those who we are considering or are already treating with life-extending therapies, to anticipate and consider the option of discontinuation of those therapies and to actively discuss that with our patients and their families, and to reassess that over time as things may change clinically. There's a class 2A recommendation in our heart failure patients to use advanced directives and to allow that to help us center our care delivery around our patients' needs, document their treatment preferences, and even talk about what end-of-life care would look like based on their preferences and wishes. There's a class 2A recommendation in our stage D patients, especially to involve and consider specialty consultative care from our palliative care consultants, really as a means of improving quality of life and relieving suffering. There's a class 2A recommendation for patients who may have a shorter expected duration of life expectancy for timely referral to hospice care. There's a class 1 recommendation in the guidelines as well if it is in alignment with goals of care for patients to be considered and referred to an advanced heart failure specialty provider to consider advanced therapies such as heart transplantation, LVAD, or palliative inotropes. So moving on to special populations, the guidelines does provide consideration for special populations, including women with history of cardiomyopathy. There is a class 1 recommended guideline for patient-centered counseling regarding contraception and the risk of cardiovascular deterioration with pregnancy in these women. In women with acute heart failure that may be caused by peripartum cardiomyopathy and who have a reduced ejection fraction below 30%, Anticoagulation can be used in this population from the time of diagnosis to postpartum. However, the guidelines recognizes that the efficacy and safety of this is uncertain. And the guidelines maintains that women with heart failure or cardiomyopathy who are pregnant or imminently planning for pregnancy really should be counseled and avoided in terms of initiation on RAS antagonists, MRAs, SGLT2 inhibitors, ibabradine, and vericiguat due to significant risk of fetal harm. Though we won't talk about the cardio-oncology population in total, we will discuss the cardiac amyloid population. So in patients who have a clinical suspicion of cardiac amyloidosis, we are charged from the guidelines with class 1 recommendations to screen these patients with serum and urine monoclonal light chains to evaluate for AL amyloidosis. And in patients who we continue to have high suspicion and do not have these markers present, they should receive a technetium pyrophosphate scan to confirm the presence of transthyretin cardiac amyloidosis. If that diagnosis of transthyretin cardiac amyloidosis is made either by PYP scanning or by tissue diagnosis, then they should go on to have genetic testing with TTR gene sequencing to determine if there is a hereditary variant or wild-type variant of transthyretin present. And those patients should be considered for transthyretin tetramer stabilizer therapy as a class 1 recommendation. As a class 2A recommendation, patients with cardiac amyloidosis that is confirmed that have atrial fibrillation that is present, they should be considered for anticoagulation regardless of their CHA2DS2 VASc score. Now we're going to meet our 2 patients. First patient is Layla. She's a 45-year-old woman with hypertension, diabetes, and high cholesterol, and thus she is at risk for heart failure and considered stage A by the guidelines. And really identifying her as at risk is important to provide us with the opportunity to intervene. And so we'll see what our class 1 recommendations are for Layla. So we have class 1 recommendations to first optimize her blood pressure control, second to initiate an SGLT2 inhibitor, and third to manage her cholesterol and any cardiovascular disease with implementation of lifestyle, diet, and fitness modification, and consideration of any additional medical therapies in that regard to optimize her control. There's also a class 2A recommendation to screen for heart failure or pre-heart failure with natriuretic peptides in the stage A population. And as providers, we can use validated multivariable risk scores to help us guide our discussions with our patients and to inform our patients. Our second patient is Donna. She's a 68-year-old woman with recent heart attack and subsequent reduction in her ejection fraction to 38%. Donna does not endorse symptoms of heart failure when you see her on exam, nor do you see signs of it. However, she does have structural heart disease from her recent MI, and thus she is considered stage B. So utilizing the guidelines as a reference, a patient like Donna with asymptomatic LV dysfunction and an ejection fraction that's below 40%, she should be started on an ACE inhibitor, an angiotensin receptor blocker, or beta blocker therapy, and considered for an ICD if her EF was less than 30% and she was more than 40 days out from her myocardial infarction. Donna's cardiovascular disease would also need to be treated and lifestyle modifications implemented. So just as we've seen and we'll hear for the duration of the talk, there are challenges to initiating therapies for stage A and B patients, just like there's challenges across the heart failure spectrum for these therapies. And the things for us to know and to consider is that just screening patients for these risk factors, hypertension, diabetes, and getting them adequately treated is a known challenge. And these challenges can be particular across populations and can have disparities within these challenges. Even with known risk factors, there's barriers to control, there's barriers to treatment and treatment intensification. We know that social determinants impacts stage A and stage B, whether someone has availability and access to walkable areas in their neighborhood or physical activity programs, or food security to be able to have food access to address the lifestyle modification needs to address a stage A and stage B properly. Certainly access to healthcare, medication access, and affordability. As SGLT2 inhibitors were recommended for Layla, as we saw earlier. All of the social barriers that we had discussed with regards to initiation of heart failure therapy apply for stage A and stage B patients as well. And with that, I will turn things over to Dr. Leffler for stage C and stage D.
All right, let's get on. Hello, I'm delighted to be here today to discuss stage C and D, overcoming barriers to guideline-directed medical therapy. Oops, what just happened? There you go. I have no disclosures. 22 heart failure guidelines provide recommendations based on contemporary evidence for the treatment of our stage C and D patients with the intent to improve quality of care and to align with the patient's interests. Stage C and D are those with structural heart disease and symptoms and signs of heart failure that oftentimes those have marked heart failure symptoms that interfere with their activities of daily living and are associated with recurrent hospitalizations despite our best efforts at guideline managed therapy. So we have Elijah here. He has a confirmed reduced ejection fraction of 35%. He is age 63 and is hospitalized with dyspnea. So we're going to use him as a general example. We are including him to consider a case involving a man of color and to consider possible marginalization and structural racism associated with his disease process. He is hospitalized again for acute decompensated heart failure. We know that the burden of heart failure is manifested in poor quality of life and early mortality. So we want to optimize our guideline-directed medical therapy and also tailor to his needs and desires. So treatment recommendations for heart failure with reduced ejection fraction are displayed on this slide, and it's a continuation of Dr. Lewis's information. What we want to do is to have the difficult conversation with him about goals of care. We want to continue the guideline-directed therapy with serial reassessment to optimize dosing, adherence, and patient education. We go from step 1 on the left of your screen to step 6. For patients self-identified as African American with a New York Heart Association class 3 to 4 heart failure with reduced ejection fraction, who are receiving optimal medical therapy, a combination of hydralazine and isosorbide should be added, and it provides high economic value. We also want to consider the patient scenarios that are identified in step 3 here. Substantial evidence supports a transvenous implantable cardioverter defibrillator as it provides high economic value in primary prevention of sudden death, particularly when the patient's risk of death is caused by ventricular arrhythmia that is deemed high, and the risk for non-arrhythmic death is deemed low. Cardiac resynchronization therapy provides high economic value as well. In patients with stage D or advanced heart failure despite guideline managed therapy, cardiac transplantation provides intermediate economic value and may be considered. Evidence supports that patients with advanced heart failure who wish to prolong survival should be referred to a team specializing in heart failure, including palliative care consistent with the patient's goals of care. So we want to use our decongestion strategy while this patient is hospitalized with decompensated heart failure. This is not really new with the updated guidelines. With the new guidelines, though, the terminology has changed a bit. Improved left ventricular ejection fraction is used to refer to those patients with their previous reduced ejection fraction who now have ejection fraction that's greater than 40%. These patients should continue their HFrEF guideline-based medical treatment. So let's go back to our case of Elijah to consider what are the common factors that precipitated this hospitalization. We want to first obtain, of course, a good H&P. Look for the physiological etiologies first, such as acute coronary syndrome, atrial fibrillation, arrhythmias, acute infections, anemia, hypo and hyperthyroidism. Look again at his medication list for guideline-directed medical therapy and to review it, perhaps by another member of the healthcare team that could increase sodium retention or have a negative inotropic effect. Important. Secondly, it's important to look for behavioral and self-care issues that likely can be modified, such as uncontrolled hypertension and non-adherence to medications or his diet while home. Oh, good. Again, support your guideline-directed medical therapy during hospitalization. We want to continue diuresis, even if they have a mild reduction in renal function and blood pressure. We want to optimize our guideline-directed medical therapy as tolerated. While in the hospital, VTE prophylaxis is recommended. Also, we need to consider discontinuation of beta blockers if the patients have low cardiac output, severe volume overload, advanced AV block, or an ACE or ARNI with angioedema. The patient should receive specific education before discharge to support and facilitate self-care, of course, with that follow-up appointment within 7 days of discharge. Elijah, with his advanced heart failure, we should also include the patient in the decision-making to ask again about goals of care. Let me go back. Seems like it's a delay. Okay, maybe we're here. And initiate timely referral for heart failure specialty care. It's also recommended to review your heart failure management and assess suitability for the advanced heart failure therapies listed on this slide. Heart failure mortality disparity in African American patients has widened over time, especially in younger aged African American and Black patients, and requires urgent attention by the medical community. Rectifying inadequate guideline management is paramount while hospitalized, and to implement further preventative and therapeutic measures is indicated. This is our chance to fix anything that hasn't been fixed. He's in the hospital now. So how can we further support Elijah? Promoting self-care and healthy lifestyle habits. Case management is indicated for this high-cost, high-need diagnosis. We want to advance health literacy if needed and provide culturally tailored services for everyone. Our H&P of Elijah reveals that he has not attended cardiac rehabilitation and frequently misses scheduled appointments. Often face different disease-related, socially determined of health, personal domestic barriers to self-care, as listed on this slide. Tailored to barriers, providers can initiate interventions for promoting self-care to include assessment of current medication taking adherence and education regarding understandings for the medication taking. Common reasons for non-adherence to medications include cost, of course, access to the pharmacy itself, and knowledge and attitudes about taking those medications. So this should be assessed. Symptom monitoring. We need to recommend that the patients monitor their symptoms and teach them how to do that. Patients often delay for days before seeking care for symptoms of heart failure at home, particularly due to the inability to recognize and interpret their symptoms when they occur. This is especially true when other comorbid conditions exist, which are very common, such as diabetes, COPD. As patients and providers alike find difficulties distinguishing which condition is causing the symptom. So the new guidelines include recommendations for select patients with heart failure who also have conditions as iron deficiency anemia, hypertension, sleep disorders, type 2 diabetes, atrial fib, coronary artery disease, and malignancy. So that's really new. Age is often associated with multi-comorbidity and cognitive impairment. Low health literacy just complicates these matters for us. Impaired cognition is quite common and affects 25 to 50% of this population group. So involvement of caregivers is critical in this situation when other support may be needed. Dietary adherence. Sodium restriction is likely necessary in the case of Elijah. However, recommendations should be tailored. The American Heart Association currently recommends less than 2,300 milligrams per day, and it's a 2A strength of recommendation with a level of evidence C, which means limited data. Behavioral adherence. Again, these will need to be tailored to the patient, but we need to assess for them. But they need to include assessment for fluid restriction, should we not? Alcohol restriction, alcohol abuse screening and counseling if indicated. Weight loss if the comorbidity is greater than a BMI of at least 40. Exercise, smoking cessation, and counseling for those things. So interventions to overcome self-care barriers cannot be overemphasized. This is when timely referral to other healthcare provider services can really help us in the medical care. Culturally sensitive education or disease management programs may really help overcome self-care barriers, and evidence indeed tells us this is true. Connect, refer to multidisciplinary teams for case management, such as social services, dietary counseling, and/or palliative care. The needs of these patients can't always be met in our medical visits. We need help for these high-risk, high-cost patients. Assess for mental health needs, such as depression is quite common, cognitive impairment, as indicated before, and substance abuse. We need to promote a therapeutic relationship with Elijah and possibly engage family in care if appropriate. For instance, do our patients need voucher transportation? So social work is really good to help us with that, and they can advocate for the insurance companies with this. If access is a problem, we might even consider telemedicine visits and remote patient monitoring for some of his medical visits if availability of device and internet access. Review any social determinants of health information listed in your electronic healthcare record. It's also important for your institution to participate and get with the guidelines reporting. We can help eliminate disparities through concerted efforts to increase knowledge of the determinants of differences in disease burden, differences in response to treatments of the disease, and to improve those contextual factors that influence clinical outcome. So now I welcome Dr. Laverne to continue.
Thank you, Dr. Leffler. Appreciate it. So first, I'll start. I have no financial disclosures to disclose. So continuing on, we will discuss today really a continuation of the guidelines and really put them into play with a patient, Mr. Morris, that Dr. Lucy and Dr. Leffler discussed. We're going to really talk about transitioning this patient from the acute into the post-acute setting. So we'll go ahead and start with Mr. Morris, who's a 71-year-old male who was recently hospitalized and is now preparing for discharge. So Mr. Morris has a 5-year history of heart failure with reduced ejection fraction. He has concurrent comorbid conditions of hypertension, hypercholesterolemia, and atrial fibrillation. He currently resides at home by himself. He does have a daughter that lives about an hour away who helps him take care of himself as well. However, she works as well. He's had multiple hospital stays over the last 3 years. We found that he's had more and more frequent hospital stays in the last 6 to 8 months. Upon discussion with him, he's having difficulty with his treatment regimen in the past due to frequent hospitalizations that have required frequent medication changes. So now let's talk about the transition of care and the type of communication that needs to be coordinated prior to a patient leaving an inpatient facility to the outpatient setting. The first thing that we have to talk about is ensuring that the patient has a follow-up with either their primary care or their cardiologist within 7 days. This is a Class 2A recommendation. Next is a referral to a multidisciplinary team that Dr. Leffler just finished discussing. This could include physical therapy as well as social workers, pharmacists, etc. This is a Class 1 recommendation. The participation in benchmarking programs to ultimately improve the quality of care and to ensure that goal-directed medical therapy is being followed, Class 2A recommendation. We've heard a lot today about social determinants of health and really addressing these, and this is going to be extremely important, especially in the home health post-acute setting, looking at the high risk factors and the concurrent comorbid conditions that these patients have. Frequent adjusting of diuretics, and as well as the coordination of laboratory checks in concurrent combination with these adjusting of diuretics. So there's some challenges that we see, especially coming from the acute to the post-acute, very much being fragmented and siloed from the healthcare. Ultimately, unfortunately, we know that it can result in poor care coordination, higher levels of readmissions, and ultimately suboptimal patient outcomes. We all know heart failure treatment is very complex and will require a multidisciplinary team. There's been a habit of cost shifting, which is unintentionally takes precedence over outcome measurements in the current healthcare industry. Focusing on improving short-term financial performance instead of outcome improvement perpetuates a cycle of runaway costs for treating chronic diseases. And as we all know, financial success for the healthcare professionals does not always equal patient success or improvement in outcomes. So now we'll continue with Mr. Morris. So Mr. Morris is now being transferred from the hospital setting into his home with home care. First thing that we have to do is ensure that Mr. Morris is being evaluated in a very timely manner. One goal would be to evaluate him in his home care setting within 24 hours. We know that many patients are at risk for rehospitalization, especially within 72 hours of discharge from the hospital. So we really want to try to see Mr. Morris as soon as possible. We want to do a complete heart failure evaluation and an assessment in his home setting. One thing that I will say too is a psychosocial assessment and a heart failure evaluation in the home setting can look dramatically different than what it looked like in the hospital setting. We need to incorporate a multidisciplinary team for the evaluation, particularly nursing as well as a therapy team. This may include social workers. This may also include pharmacists as well. Next is really looking at medication reconciliation and discussing the importance of his medical regimen. But equally important is looking at any beliefs and concerns that he has about his current medication regimen. You know, in discussing with Mr. Morris, what we found was on his last hospitalization, he was prescribed an ARNI. While in the hospital, he took his ARNI with no problems. When he got home, he stopped taking his ARNI because it made him very dizzy. He did not tell his providers nor his daughter. This likely increased the chances of him being readmitted to the hospital. Working closely to understand why he stopped taking the medication, we were able to work with his providers to adjust his medication regimen and ultimately get him back on goal-directed medical therapy. Looking at self-care compliance. Again, looking at social determinants of health that both Dr. Lucy and Dr. Leffler discussed. Looking for any food insecurities. Really evaluating his current health literacy level and really working with him on that. Evaluating his transportation issues, not only to and from provider appointments, but also to and from the pharmacy, and possibly coordinating with the pharmacy for delivery of his medications when he needs. And also any financial burdens that he may have that could cause him to be less compliant with his regimen. Evaluation with his ADLs as well as IDLs, and where are his goals. We want to then individualize a heart failure care plan to optimize his treatment and his regimen. Really working with Mr. Morris to understand what are his goals for therapy and working in combination with his providers so we can effectively meet those goals. Ongoing assessments, as discussed earlier, utilizing remote patient monitoring and virtual visits to constantly work with Mr. Morris to pick up on small cues that could eventually decrease his outcomes. Care compliance plan, really looking at his plan of care that we established in conjunction with Dr. Morris to see if he is being compliant with his plan of care, and if not, what interventions can we put into place that can help Mr. Morris. Ongoing communication with all clinicians. This should occur at least weekly with the multidisciplinary team to discuss Mr. Morris's conditions, any interventions that have been made, or any recommendations for interventions that should come. The optimal solution here is to really develop a very robust, standardized method of treating heart failure patients in the home care setting. Having a very specialized program, which includes comprehensive education, not only for the staff, but for the patients and the caregivers. And this education for the patient and the caregivers really goes into a lot of detail of teaching the patient and the caregivers how to effectively self-manage their condition. Collaboration with clinicians in the hospital system to ensure that we have flawless transitions of care. You know, one thing that we have not used a lot in home care is heart failure classifications to in turn ensure that patients are on goal-directed medical therapy. We want to ensure that we are getting the heart failure classification from the hospital system so we can ensure that this patient is on goal-directed medical therapy. Close real-time monitoring of the patient. Admitting the patient early, monitoring them very, very closely, which, like we talked about, could include remote patient monitoring. Protocols in place that could adjust to changes in the profile, such as if he's had a weight gain. Do we have protocols in place to increase his diuresis for so often? Strict following of evidence-based guidelines, and ultimately performance improvement processes in place to ensure that we are measuring our outcomes and working to make changes to ultimately improve these outcomes based on evidence-based guidelines. So the American Heart Association has worked closely with the hospital systems to really work on this continuum of care from the acute to the post-acute. And some of the ways the American Heart Association has worked on this is starting 3 certifications. One being a American Heart Association certified home health heart failure program, as well as a skilled nursing facility and a palliative care hospice heart failure certification as well. So now I'm happy to report, as we've used these guidelines to really care for Mr. Morris, we've had some great results. Number one, he's gained a thorough understanding in his regimen, including his prescribed medications, how often he should take them, when he should take them, and if he has issues, what exactly should his plan be. He was able to increase his activities, especially with his ADLs. He reports that his shortness of breath has decreased and he's able to get around his house much, much easier. He now weighs himself daily after education on the importance of that, and logs his weight and brings it to his provider appointments. He also has a plan in place in the event that he gains 2 to 3 pounds. He got permission from his provider to increase his diuretics as discussed. He was able to modify his diet as well and decrease his sodium. Ultimately, he recently went to his provider and had an echocardiogram, which showed an improvement in his ejection fraction, and ultimately his quality of life has improved with that. We're able to utilize community resources, especially for his dietary intake and his medication regimen. He's been successfully discharged from home care after 60 days. He does have regular follow-ups with his primary care as well as his cardiology team. And I'm happy to report that he continues to remain at home in the comfort of his home and has not been readmitted for hospital readmission in the last 9 months. Thank you so much for your time today, and I'll turn it back over to the American Heart Association.
Thank you so much. While I'll be going over a few of the resources we have in place for you, take your time to enter your questions in the Q&A panel that is there available on your screen, because this is a real quick set of resources. You'll be receiving these slides, and these are workable links so that you can actually click into these. So please put your Q&A in there, and we'll get to those shortly. But wanted to bring you a number of supporting materials. When we have a new guideline come out, you know, this is really the last time the whole heart failure guideline was out was 2013. So when you have a 9-year difference between those, it may require a good number of resources to get up to date. So we are providing the links, of course, to the guideline, to the infographic, which is, of course, we believe one of the best ways for you to be sure you're getting guideline-directed medical therapy is through the use of Get with the Guidelines Heart Failure. So this really, you see those fancy charts, this really kind of breaks them down to where to start, as well as some information on top 10 things. I encourage you to look at the Cardio Nerds podcast. Those are short educational series you can use for your staff to get up to date on these new guidelines. Jumping down, some resources that you can actually purchase and use to get up to date on the guideline in particular. And again, you will have the links for each of these resources. As I mentioned, one of the best ways to get started in making sure you're getting guideline-directed care to these patients is through Get with the Guidelines Heart Failure, where we start with the very simple, basic top 4 for your patients. Then we provide a more in-depth set of quality measures that you are encouraged to work through, and all of these are on those charts that you were seeing related to the guidelines, and then even target heart failure, so taking that quality journey even the next step. So we encourage you, if you're not using Get with the Guidelines, to take a look, and if you are, to work with your quality consultant to make sure you're using it fully. But these guidelines within Get with the Guidelines match the 2022 published guidelines. If you are not using AHA Guidelines on the Go, the mobile app, this is a wonderful tool, not only for this guideline, but for any of those that are put out by the American Heart Association. So I encourage you to get that on your phone. You will find it very helpful and almost easier to work through the algorithms using your handheld device. So I encourage you to take advantage of that. And then some downloadable and interactive resources that you can use with your patients. In particular, the discharge packet in both English and Spanish has been updated to match the guidelines, and that's available. You can use it online, or you can have it printed in your print shop. If you're going to use online training, I would encourage you to use the interactive workbook, which is a 48-page online guide. So perhaps for some of your younger patients where they're working through all of the guidelines for them. And you can see down here, I don't need to name all of these, but many pieces of information that are appropriate for healthcare professionals. And then also some basic patient education sheets as well as the support network that patients can use to find online community. We did include the evidence gaps and future research directions that were provided by our writing committee. So as you look at things that we need to study further, that's what this is a list of. And then I do want to, we used many of the slides that came out of our guideline committee, and so wanted to make sure and acknowledge those individuals. And so let's do some Q&A. And Steve Dental, my partner in crime, has been looking at our at our questions. So Steve, any questions for our speaker today?
Yes, thank you so much, Sri, and thank you for those that submitted questions. We'll try to get to as many as we can. Dr. Lucy, one of the questions that came in is regarding SGLT2 inhibitors for stage B patients. What are the recommendations around using those medications?
So as I highlighted for our stage A patient who had diabetes, there was a recommendation to use it for that patient. In patients who are pre-heart failure, stage B, who have structural heart disease or who have evidence of elevated natriuretic peptides or elevated filling pressures and have an indication with regards to diabetes, then there is an indication to use it for that purpose. In the absence of diabetes, there's not a specific recommendation for SGLT2 inhibitors in the stage B population, but certainly if they have progressed to stage C, SGLT2 inhibitors should be initiated in symptomatic heart failure patients.
Great. I believe this is for Dr. Leffler. Have they changed, or Dr. Lucy, either one of you, have they changed the recommendations for ICD from ejection fraction of 35% to an EF of 30%?
No, I'm not aware of that. Dr. Lucy?
No, so in the case of non-ischemic cardiomyopathy, we may use a lower ejection fraction of 30%, but for those who have ischemic substrate as the etiology of their cardiomyopathy, then the EF of 35% or below that has not recovered and they're far enough out from either a revascularization attempt or proven guideline therapy for the recommended period of time, then at that point we recommend ICD therapy. I hope that clarifies it.
What are the recommendations around quadruple therapy for heart failure patients with an ejection fraction of less than or even greater than 50% EF?
I'm happy to take this one. So, so it sounds like the question is with regards to the heart failure with preserved ejection fraction population. So someone who's symptomatic and has an EF 50% or above. As we saw, there's class 1 recommendation certainly for diuretics and blood pressure control in this population. There's a class 2A recommendation for SGLT2 inhibitors, and then a 2B recommendation for the use of RAS antagonists. The ARNI complex being one of them, ACE inhibitors and ARBs, and mineralocorticoid receptor antagonists. And those really can be considered in the population of patients who have had heart failure hospitalizations, and you want to reduce those heart failure hospitalizations. Because of chronotropic incompetence that we often see in this population, we tend not to use beta blockers, specifically when the EF is above 50% in the symptomatic group. So those would be the recommendations for 50% and above. And I should say one caveat, as I mentioned in the talk, when the EF is to the lower end of the spectrum, so it's 50 to 55% or 50 to 57%, that tends to be the population of patients that we reach for these additional therapies that we have 2B recommendations for, because the data from, for example, a Paragon sub-study, when we saw that the EF was below 57%, that's where we saw a benefit for ARNI in that population of patients who had the lower end EF. So that's why that extrapolation is put there into the guidelines in patients who have HFpEF in that lower set of the EF spectrum.
Question for, I think this would be applied to all of you. And we can start with Dr. Leffler and then go to Dr. Laverne and then Dr. Lucy. You know, how can we get cardiology to work more closely with primary care to make sure the patients are getting the optimal care involved?
Yeah, I think it's a great question. It's to really start within your system, your healthcare system, and Dr. Laverne, really break in anytime you want. But we do have to break down those silos, as he mentioned in his talk, and work together. So those early referrals, timely referrals, not waiting till late, talking about goals of care really early before that patient gets in the hospital, and then trying to determine what groups that we need to be involved right now, what groups need to be involved with something else happens, but to bring them in at the front end and get a full complement of your interdisciplinary colleagues as soon as possible. And the evidence is showing this now, and the new guidelines really highlight that.
Yeah, I couldn't agree more, Dr. Leffler. That is correct. You know, for us, especially in the home care setting, we're dealing a lot with the primary cares. But what we want to do is, you know, a lot of times the patient has all these comorbid conditions that the primary cares are taken care of. But what we want to do is try to incorporate the cardiology to take care of those basic cardiac needs, to really bring all the disciplines together to care for this patient. So when we're talking about the multidisciplinary team, you know, I talked about the therapists and the nurses and the social workers, but that also includes the primary care as well as the specialists, all working together to benefit this patient, to improve their outcomes. You know, because, you know, the mismanagement of hypertension could lead to decreased outcomes, right? So it's not just from the heart failure, but it's managing all these conditions and managing the patient as a whole in more of a holistic type care.
I would echo everything that's been said and just drive home the point of communication, communication, communication. The electronic medical record does help us with that, but sometimes it does require picking up the phone and faxing the letter, sending it, and just making sure that we're all on the same page. For me, I reiterate to my patients and to the primary care providers I'm working with, these therapies are absolutely life-sustaining therapies for you, and they should not be stopped unless it's under XYZ conditions, and you can always reach me and we can have a conversation about this. And so I think as long as there's a two-way street in communication, and primary care and cardiology knows that they're working together to manage not just the heart failure, but all the comorbidities that the guidelines highlights that we're responsible for, that will give us the best outcomes for our patients.
Next question is, do you recommend external defibrillators for patients with an EF less than 35% while waiting to optimize guideline-directed medications?
So I think this is with regards to not implanted, but perhaps the wearable defibrillators. So it depends on the particular scenario, and this is something that in my practice we do case by case with regarding if it's an ischemic substrate that's underlying, or if there was some other arrhythmia concern. That's the unique scenario in which we use that. However, for patients who have not seen guideline-directed medical therapy, have not had sustained ventricular tachycardia, and do not have ischemic substrate, and do not have a familial risk factor for a high arrhythmia burden, then that population of patients we tend to get on therapy first before we commit them to a defibrillator of either kind.
Yeah, and I'll echo too. I think it's important too, Dr. Lucy, you know, if you guys decide in the hospital setting that you're going to place the patient on an external defibrillator, that it's communicated to us on the home care side to ensure that the patient is being compliant. And if they're having troubles with it, we can communicate it back to you and your team to coordinate that care.
Absolutely, yes.
I think we are at the top of the hour in terms of wrapping things up. The first thing is, there was a couple questions about different resources that people are looking for. We will make sure that we follow up with everybody with necessary resources to answer your questions around social determinants of health, post-acute care. So we will make sure that we do diligent follow-up on the couple of requests and questions. But I will turn things back over, you know, as we're wrapped up the question section.
Thank you so much, Steve. So thank you to Dr. Lucy, Dr. Leffler, and Dr. Laverne for sharing a remarkable presentation and for your continued dedication to the community and to the American Heart Association. And thanks to all of you for attending. Once you leave today's webinar, you will receive an email with a short survey, and we would appreciate if you would complete that and provide your feedback. You'll also get a follow-up email within 24 hours with a link to view a recording of today's webinar, and it will also include a link to your certificate of completion. So on behalf of the American Heart Association and our speakers, thank you for joining us today and have a great rest of the day.